Thanks, Liz, for having me, and it's a great pleasure to be able to speak here. I've had the pleasure of working with Dr. Lipner here for, we won't say how long, but it's been a long time, and it's been a great relationship between the interventional societies and communities, as well with the ABIM interest in looking at simulation for this. So I'm going to just go over an overview. There have been some great speakers. I think David really summarized a lot of the technical issues with metrics and evaluation. I'm going to focus a little bit on sort of where we see the role. I think interventional cardiology is one of these procedures that's really a visuospatial procedure in that you're working on a patient, but you're actually looking up away from the patient, much like Dr. Satava was talking about the robotic surgery. And it really requires a lot of integration of CT images, echo images, X-ray images that really aren't hands-on type things. So I'm going to kind of go over some of the status of this in interventional cardiology as we go forward. So sorry about that. So it wouldn't surprise you that the learning pathway, and as a program director, I've been the program director for the last 10 years and meet with all the program directors around the country. This is actually still the learning pathway for interventional cardiovascular procedures. You know, all of us get 5 to 6 throwaway journals every month in the mail now that highlight the novel technologies, the new procedures, the FDA approvals of all these procedures, and the sort of tips and tricks on how to introduce these into your practice. Most of us are lucky enough, me being at an academic institution, we're encouraged to go to our annual and semi-annual meetings. But again, these are didactic lecture, PowerPoint lectures here on how to do very complex cardiovascular interventions, and that sort of is how I get my education currently. We get lots of email links from industry to go to a webinar, and I just don't know how valuable webinars are for me gaining skills on new procedures, but that's what's going on. We are lucky to have experts fly into town, into Denver, from time to time to talk about these things. We watch live cases and now taped live cases, which is an interesting approach. But really, all of us practice on patients in our hospital settings. All of our fellows are doing this. When I walk in and I ask a fellow, have you ever done this before? They say no. They're always eager to get up and get going. And so I just highlight that this is still the paradigm. And maybe, you know, I'm being, you know, I think, you know, our fellows are competent to do this, particularly, you know, I'm dealing with PGY 8s, 9s, and 10s, so I'm pretty blessed because I'm dealing with folks that are pretty skilled, but still, suffice it to say, we have brand new procedures coming around every day. And I'm going to highlight some of these. I think most of you have seen these slides, but this really looks at sort of why simulations may be helpful. I think, you know, it really looks at interactions that are the interaction of participating in a simulation really is the key to gaining some benefit from education. And people who've participated in simulation have been documented in multiple venues to learn faster and have better attitudes about their education. I think it's a more engaging approach, and particularly for us being very visual folks, looking at X-ray monitors, hemodynamic monitors, simulation actually is a lot more similar to our environment than perhaps for many other environments. So Eisenberg, this reference has been shown by several of the speakers, but really talks about developing training tools to try to imitate anatomic regions. In interventional cardiology, if I would have given this talk a decade ago, we would have been talking about coronary angioplasty. I'm going to talk a little bit about the breadth of this now, but there's nothing that we don't do in interventional cardiology that isn't from the toe to the top of the head. This involves peripheral, structural, coronary, and cerebral interventions and diagnostics. And to train people in that field in a very brief period of time really does require simulation training to help get them up to speed. I think, again, defining the clinical tasks, thankfully, the wire and angiographic techniques useful for these different areas, I think, are well suited for simulation. We can develop fairly realistic simulations because you actually don't need a live patient there. An X-ray image of a beating heart that can be made to look fairly realistic isn't very different than when I'm doing your angioplasty or your valve intervention in my own hospital. So I think Dr. Satava really talked about this well earlier. You know, this concept of only learning on a high fidelity simulator really is a challenge, but I do think certain tasks are well suited for this. In particular, I'm going to highlight maybe 3 or 4 of these in interventional cardiology that you really can't train on with a partial task trainer. A lot of these things are really complicated, multi-step procedures that not only involve one person, but now we have devices that involve 2 or 3 individuals implanting percutaneously at the exact same time and in a coordinated fashion. discussion. I'm going to show you some video from our simulation training that I was just at this last week for interventional and cardiothoracic surgeons, just highlighting how useful I think simulation is for these more complex procedures. All of us, have been spurned by the Institute of Medicine report, and I've had the pleasure of working with both the NBME and AHRQ as well as the ABM on simulation training and diagnostic and interventional cardiology. I think, all of us have responded to this to try to ensure that clinical training is safe for patients. I still think we have a fair distance to go to ensure that. I do think that we've done a tremendous job, and you'll see some of the vendors here, but there are some great vendors that I'm going to highlight that are really out there, and in the last 2 to 3 years have really are bringing phenomenal technology that's much more affordable to the environment that we can use. And then really, I guess, highlighting back the concept of individual and team performance. These are team performance things that necessarily need a novel approach to training, and in simulated environment really is one where I think team training is very useful. I know David spent a lot of time in this, and these are complicated areas to actually get metrics on when you're trying to measure a team of who's really driving those. The big issue for us in interventional cardiology is crisis management, and the malignant hyperthermia is a perfect example of you want to deal with the things you see once. Yesterday, just as a quick story, I got called from my partner at the VA, and they had a coronary perforation. I've done maybe 1,000 coronary interventions in the last 7 years. I've not had a coronary perforation, and we've talked through how we were going to manage this. It's a very complicated thing. None of us are exposed to these things, these catastrophic, life-threatening problems in any frequency to be facile with this. And so the only bailout that we had, which was a covered stent, wouldn't fit in this patient. So we had to go through a whole algorithm of approach to this. But it just highlights these sort of very infrequent but very catastrophic things that are potentially ralliable with the appropriate training are critical for training and simulation. Just to, again, the features of simulators that are useful, particularly for an interventional procedure. And when I talk about interventional cardiology today, you can substitute vascular medicine, you can substitute interventional radiology. These three fields, in addition to cardiothoracic surgery, are really merging in 2015 by the time we all will be doing very similar skill sets. So I think this is going to require different training approaches, but if we can train the same way using simulation, that will be useful. Force feedback, the ability to use real catheters and real sheaths and real wires are really a critical aspect that the simulation companies have allowed us to be able to use in 2012. We can now practice, and I'll get into a little bit about this, about pre-procedural rehearsal. The range of difficulty now, I think we've been able to do this. I think we started off for ABIM, Rebecca, maybe with 20 case scenarios, and through consensus approach, through 20 interventionalists with 20 different opinions, we were able to whittle that down to a fair number. But it does take some time to come up with a broad spectrum of difficulty for this. And then I think the validity and realism, everyone's touched on. I think the acceptance of the interventional community from the data that Rebecca showed has been consistent across multiple studies. They feel that this is useful for training and testing, amazingly enough, as a group. So I'm just going to skip over this because I think, this has been covered in detail by all the other folks. But, interventional cardiology carries significant risk. Percutaneous aortic valve replacement, of which we're the only program here in the Rocky Mountain region doing this, carries a risk of about 5 to 10% of mortality for the procedure that I did yesterday. When you're talking to people about a 5 to 10% risk of death, that includes about a 10 to 20% risk of other major bad life-threatening issues. And so these are high-risk fields that we're delving into. Neurointerventional procedures, vascular interventional procedures, much like you talked about endovascular therapies of aneurysms. These are procedures that have palpably and logarithmically more risk than what we were trying to train on the simulator just 5 years ago. And so the second issue that goes along with that is as these are becoming more complex, they involve more operators, they involve more specialties. So we now have procedures being done by vascular surgeons and interventional radiologists, interventional cardiologists, neurointerventionalists, and vascular surgeons. So we now have to do team training even within our own realms. In the United States, we have too many low-volume centers doing with many low-volume operators, and that is the big challenge that we face. We've just not done a great job of centralizing care. We have 32 angioplasty programs here in Colorado. So if you're going to have a heart attack, it's a very good state. We have one of the highest per capita angioplasty programs. I think there's 18 in all of Canada. when I was up there last year. So it just highlights that other countries have been able to centralize these key services so that all of the people there are high volume operators, and they buoy the system through that. We need to adjust a training program that fits our realities here in 2012 in the United States. The training does need to be safe for patients. The fact that you can do a complex procedure never having practiced it once outside of a patient is a little bit problematic. And then I think the thing that's the newest to this arena is the use of patient-specific anatomy. So if you come in for a complex intervention that myself or one of my partners is doing, it would be terrific if we could import all of the data for which you were exposed to contrast and radiation and rehearse that case before we get in and do your case, and do all the pre-procedural planning such that you can have plan A, plan B, plan C. You know the catheters you're using. You can minimize radiation in contrast to the patients. So this whole concept of rehearsal, I think, is really gaining a huge traction in this area. There's actually 4 simulators, and I apologize, I don't have the CAE simulator on here, but it was from Immersion Medical. But CAE is a huge flight simulator company that's purchased that. But in endovascular simulation, SimSuite, the MSC, which is actually based here in Colorado, Mentis and Symbionics really have a huge traction, and all have really had significant improvements in their haptics, in the angiographic display, as well as the content and the breadth of programs that they're able to train folks on. Sorry about that. Let me see. There we go. So just in cardiac catheterization, had I have given this only 4 years ago, we'd be talking about coronary angiography, angioplasty, and carotid stenting. Those were the 3 programs that really are out there. Those are the only 3 programs that really have any validation studies done. And with that, as Rebecca said, very few validations studied in that fashion. But suffice it to say, coronary angiography is a huge thing. There's 1 million procedures of these performed in the United States each year, so these are not infrequent procedures as inpatients, and then about another 1 million as outpatients. So it's a huge cost, huge procedure with a high, obviously, risk of complications. I highlight here femoral access and radial access, and I'll get back to that. Right heart catheterization, which is relatively straightforward. Angioplasty with balloons and stents is pretty, I would say nowadays, pretty routine. When I started in the early 1990s, when we didn't have stents, blowing up a balloon and tearing a blood vessel was not something that you appreciated, because about 20% of people came back that night emergently with closure of that vessel. But with stents, the complication rates are incredibly small now. Acute closure of the vessels is less than 1%. Major complications is less than 1%. But what you do need to do is be able to train people on the 10 catastrophic things that can happen: coronary perforation, acute coronary closure, need for emergent bypass surgery, things like that. And then specialty tools. We've got a huge number of new tools. The route to FDA approval in the United States, you would be surprised at. If you have a device that is similar to something else, that device goes through 510K approval, which means it needs to be used in 100 to 150 patients to shown to have somewhat similar safety to a previously approved device. That's how many of our products are used. So when you're getting it as a patient, it may have never been used in more than 200 people in the United States. With that, there are training issues that go with novel device use, and then complications magically occur in the community where they gain experience with that. Transradial intervention, this is actually a hot topic right now. In Europe and in Canada, about 90% of all the procedures are performed through the radial approach, so diagnostic and therapeutic procedures through the wrist. The big advantage of this is that it minimizes bleeding and minimizes complications at the vascular site, particularly in women who have the highest risk of bleeding and complications. In the United States, 3 years ago, this represented 1% of all coronary interventions. And with this big push to reduce hospitalization, minimize bleeding, minimize complications, in the United States, this is actually skyrocketing to where we're up to about 10% of angioplasties performed in 2012 in the United States are going to be done radially, with about 20% of diagnostic caths. The challenge with this is that most faculty do not do radial angiography. So when I picked this up 2 years ago, I had to go get licensed in Indiana. I went and worked with a cardiologist who had done it for 15 years and practiced on his patients with him supervising me. But for the majority of people, they're actually picking this up in their practice by going to a weekend course. The beauty of this is that this transradial program, which is sponsored by Society for Cardiac Angiography and Imaging, has actually been regional. There's been about 10 of these around the United States, and we've incorporated simulation training. So there's a didactic curriculum that's been developed by experts in radial angiography. There's a basic and an advanced course, and this has all been done in conjunction with simulation. So when you go to do this, you're literally sitting down at the simulator with an expert going through the tips and tricks of getting up and started and then more complex intervention. So this has really been a very exciting field for us, because this diagnostic approach to angiography, which is a very common procedure, is now a route by which many people can be exposed to simulation training who are actually in practice, not just training programs. And this is one where many of the fellows, my 2 fellows that are finishing this year, have each done over 500 procedures. They're going to go out and actually teach the faculty at the programs that they're doing this at. They're actually better than most people doing it, so it's been great. But the simulation component of this is a huge, huge advantage, being wrapped around the didactic component and having hands-on training. Peripheral intervention is just a whole nother area that has exploded. This actually has caused A, turf battles, but B, a great opportunity for our colleagues to work together. I work very closely with our interventional radiologists, vascular surgeons, cardiothoracic surgeons, and that we all practice out of the same cath labs, which has been great because I learn all the different skills from our interventional radiologists and neurointerventionalists. I actually had an interventional radiologist come with me yesterday to help on this case because they have great experience with coiling things that are bleeding. So, but suffice it to say that the routes, as Dr. Satava had brought up earlier, is that they approach things in these different specialties very differently. The peripheral simulation is one way where the companies have basically allowed us to create a generalized didactic curriculum that gets everyone on the same page. So whether you're a vascular surgical resident or attending, a neurointerventionalist, a cardiologist, or a cardiothoracic surgeon, everyone is learning the same basic access, wiring techniques, balloon, catheter equipment selection techniques using simulation. And nowadays this involves high-risk things like carotid stenting. Carotid stenting required by FDA requirements requires simulation training for you to actually become certified to be an interventionalist doing carotid interventions, and that was the first FDA approval ever that required simulation training. But now aortoiliac stenting, treating complex aneurysm repairs with these incredibly complex multi-component devices, is another huge realm of simulation training that is being used for not only interventional cardiologists, but vascular surgical colleagues and interventional radiologists. And then the biggest area of explosion is really in what's called structural heart disease. I think most people aren't that familiar with this because we really haven't had great treatments for structural heart disease until the last few years. And it was interesting on Rebecca's slide, the 2 things that are the most interesting for simulation happen to be percutaneous aortic valve replacement and valvuloplasty, which is a requirement for percutaneous aortic valve replacement. This is a revolutionary technology in that we're able to now put in fully through the femoral artery and actually a full working aortic valve. It's right now it's FDA approved for those that are deemed not surgical candidates under CMS. But I'm going to go through some of the training routes that I had to go through, because before we did these on folks that were not operative candidates, which you could imagine, mean age of 87, multiple comorbidities, renal failure, heart failure, frailty. That's not a group of people that does well with any complications. So you need to make sure you get them through these procedures very cleanly. But this is a huge area for simulation. I'll go through some of the simulation. The simulation for this is out of this world. I mean, it's just phenomenal now. Transeptal puncture, which allows us to go from the right side of the heart to the left side of the heart to work on valves, is something that all of my senior faculty did blindly with X-ray. We now do with ultrasound, but it's a procedure that really wasn't needed. It fell out of favor for about 20 years and is now firing back up as our electrophysiologists, and we work on the left side of the heart for treatment of atrial fibrillation. But it's a skill set, again, associated with major comorbid conditions in hospital complications, about 5 to 10%. And then congenital defect closure. We now have valve treatments for clipping the mitral valve, so you no longer need open heart surgery and valve replacement for severe leaky mitral valves. These are all very complicated procedures, the metrics for which still need to be developed, but I'll try to summarize some of the metrics that are useful for these. I think the current generation simulators are terrific. I think you'll have an opportunity to see one of them today. The major advances in the last few years is now we're actually using the exact equipment to put into the simulators, so you understand how these things torque, you understand when you have things with dials, triggers, how those work, and importantly, how those look in X-ray and in two-dimensional space. We also can integrate ultrasound imaging, which we use pretty routinely now, and CT and MR imaging into these so that people can get work on their visuospatial skills and three-dimensional skills as well. The hemodynamic monitoring is pretty part and parcel, and all the companies do a great job of integrating that. There are full pharmacology models in all of these simulators that allow, if you give drug A and drug A is a good drug, it helps your problem. If you give drug B, and drug B is a bad drug, or you give a log dose error, there are catastrophic consequences of the patient. These are great ways of tracking, some of these complications in decision making, much like the epinephrine story that was talked about earlier. The metrics that we've really focused on in endovascular simulation have been the ones that I think people have focused on to some degree in the surgical simulation, which have been things that you can measure, so procedural time, fluoroscopy time. Fluoroscopy time is a surrogate to radiation exposure, and the more radiation you get, the higher your lifetime chance of developing cancer is. Catheter advancement, how long it takes you to do this, how many errors you make, how long it takes you to wire a vessel, and how many errors you make. Do you take the appropriate diagnostic images, the number of them, the right projections to make a diagnosis? And can you appropriately select devices? Can you appropriately position the devices? And importantly, can you use them in the right order to get a good therapeutic effect? I think finally, the thing that is the most useful is the use of simulated adverse events. And this is a way we've developed this, SAEs as we call them, basically to ensure that everyone gets the same complication such that you can measure their time to response. Did they need a mentor? And when they responded, did they have inappropriate or guideline discordant treatments of those? We've been shocked testing physicians and looking at their outcomes with that. The validation studies really are I'm going to present just two of them here. They're very, very limited in this field. These really have been, the better data is probably in the vascular medicine realm and carotid realm rather than interventional cardiology realm. And I think the hallmark of all these, though, is that the trainees think that these simulations have face validity as well as the ability to be used for both training and testing, which is a good thing when we're trying to introduce this. There really hasn't been any impact on clinical care. I noticed, David, your slide where you had simulation training, it took till about the fifth line where we got to clinical benefits. But I think that we probably can start showing those as we get more and more sophisticated with these, training, higher up folks on some of these newer procedures, and I'll hope to highlight that. Patel in 2006 did really the first validation study looking at simulation training in carotid intervention, and they took 20 practicing interventional cardiologists, and they actually instructed them using standard didactic approaches, and then basically showed over 5 simulated cases that they could decrease procedural time, decrease fluoro time, contrast volume, and catheter errors. And this is the type of study that's out there. N of 20, not a ton of patients, or not a ton of subjects, but we're able to show over repetitive simulations that procedural skills theoretically improved. Catheter manipulation errors, movement errors, and cannulating the wrong vessel also tended to decrease over time significantly, suggesting that with repeated training that you could actually improve skills. And these were all statistically significant, albeit, with multiple repeated measures. I think one of the more interesting ones was this study by, I think it's Scher from Columbia, and this was a peripheral vascular intervention study. This was actually one of the first VR to OR studies, actually, and the only one that I can find in the literature. There's actually some in the surgical literature with laparoscopic skills, but this is the first one in endovascular. And this was actually 20 surgical residents that they took. They randomized half of them to simulation-based training versus standard didactic training. They then had mentors observe them and do a global scoring system as they performed 2 simulated cases of lower extremity peripheral arterial disease in a OR angiographic suite. So these were live cases that they were actually evaluating them on. And resident performance then was graded by these surgeons in both a blinded fashion through 18 procedural steps. They did a checklist for all the procedural steps, but also did a global rating scale. And I apologize for the complicated slide, but basically procedure 1 and procedure 2 on the left-hand side, the simulator, I guess it's your left-hand side, the simulator trained group compared to the non-simulator trained group to the right had statistically better performance along the checklist approach in almost every column. And when you looked at the mean global rating for the procedure, the simulator trained group did far more superior in their 2 cases compared to that group. So this is really this is how robust the literature is in this area. So suffice it to say, there's a lot of room for improvement. Rebecca did a terrific job of presenting the ABIM validation study, and I had the pleasure of working with her as well as multiple members of the interventional committee for the ABIM. And as she said, this was really 6 interventional simulations that were created. This was this was a study that actually recruited subjects from 10 hospitals around the United States, and we looked at a total of 115 subjects that underwent this training. So it was actually a fairly large group of folks. And one of the things that I just wanted to point out, and I think that we figured out after, is that when we talked about skilled versus expert, the skilled group of people were people who were in fellowship or had finished fellowship, I think, within 2 years. At my hospital, my interventional fellows do every case for their 2 years that they're with us. So while they're considered, in this group skilled, there isn't much that differentiates them from the expert folks. These are folks that are really doing it. Many of the experts, who are 10, 15, 20 years are watching other people do cases and count them as their cases. Not to say they don't have expertise in them, but the actual catheter manipulation that's going on in many cases in many academic programs where we recruited these from, the interventional fellows and junior faculty are really driving this. So I don't think this was sort of a reflection of the actual simulation issue, but was a reflection of the fact that who we call experts may not necessarily be the right expert referent group. And these were already shown, so I think the one thing that is important is that within simulation training, particularly for interventional cardiology, is not just about the haptics, not just about catheter navigation. And I really think de-emphasizing this whole thing of how long did it take you. I don't want the cardiologist who does this in 1 minute. I mean, again, things that are at the extremes, the fastest or the slowest, are probably not where you want. There's probably a sweet spot in the middle there. But you can embed cognitive skills and decision-making within a simulated environment such that you're actually having to make fund of knowledge decisions and decision trees while in a simulated environment. They actually aren't skills associated with the simulator per se of the technical skills, but they really are the cognitive skills. And I think this is one area where the experts actually were different than the skilled group in this. And I do think this highlights that this is still a reasonable environment to explore for high-stakes testing, if you will. And I think I think the use of high-fidelity simulators, with this particularly immediate feedback through a maintenance and certification route is a great one. I think we're close to suggesting in the American College of Cardiology consensus document on competency for interventional cardiology, either every 3-year or every 5-year simulation-based training as a surrogate. The average procedural volume for interventional cardiologists has dropped because there's far more interventional cardiologists and there's far more hospitals in the United States, such that the previous volume requirements that we talked about, a minimum of 75 procedures per year, which has been our ABIM certified level for the last few years, this year the median PCI volume in the United States is 62. So if the median is 62, we've got 70% of the people that are less than our ABIM target. So we're going to have to come up with some novel ways of doing this. And I won't go into the MOC training, but it's been, I think, a terrific opportunity for folks to be exposed to this in a environment. I think for the most part, when I've talked with my colleagues, particularly the fellows and folks that are going for their first recertification, which almost everyone is since it started in 1999, we have people in their second and third year of recertification. The participation in the MOC for interventional cardiology has really been terrific. I think the fact that I think it's 20 of the 100 points also makes it useful because it's a very efficient way to get there for folks. The other thing that's going on now is effective in just about 23 days. Both interventional cardiology and cardiovascular disease must have their fellows participate in simulation training according to the ACGME. And this is under the curriculum organization. And so this is going to be a huge burden. For the interventional fellows, we run a symposium once a year called the Fall Fellows Course, where we expose all the fellows that are invited to simulation. But that's only the interventional fellows. That's 210 people. But there's actually about 2,000 general cardiology fellows, none of whom really are exposed to simulation right now, that fall into these things. So this is going to be a huge area where we need some funding from the services. Did I skip forward one, or did you?
Okay, can we hold ventilation?
So this is
Turn pacemaker on, please.
Pacemaker ready?
I'll let you listen to this for just a second here. And
Okay, we confirm that our pressures drop nicely below 50. Inflate.
1, 2, 3.5, 4.
Deflate.
you hear the giggling. This is a simulator, so there's.
Pacemaker off. And resume
So
ventilation, please.
I don't know if you can stop it there, but before we go on to the next slide. But so simulation, this is preparation for the TAVR procedure, this transaortic valve replacement. This was just FDA approved. As part of the FDA, every person who does this, every operator in the United States, as well as outside the U.S., has to undergo simulation-based training to the level of competence that you actually have to document and record this, and you actually have to successfully complete all of these simulations for this. This is a case, this valve can be put in by two routes, through the femoral artery or directly through the tip of the heart, what's called transapical, which obviously is a slightly different skill set than most of us have. This is actually, and I'll show you a couple more examples, because I think this sort of training for me, this was just last Friday, really I was solidified my sort of, I've been exposed to simulation training for a long time, but this was really a first opportunity that I'd actually seen my two cardiac surgeons on a simulator. So this is actually Joe Cleveland, who's our head of our transplant VAD program, and Dave Fullerton, who is our current, who's our chief of cardiothoracic surgery. He'll be the STS president next year. But anyways, this is team training. These procedures involve three of us doing this procedure at the same time, each with a coordinated aspect. One of us is positioning the valve. It takes a separate person to be pulling back and taking pictures of the aorta as we implant this valve, and then takes a third person to be appropriately implanting and expanding the balloon, so that when you blow up this balloon with the valve mounted on it and deflate it, the valve doesn't go out the aorta or down in the ventricle. So it's the most complicated procedure, but this is what's going on now for this whole group of every technology we've developed in the last 3 years for complex endovascular treatment all involve these multiple operator, multiple step things for which we don't have a good training route. And this is where simulation is terrific. Maybe you can hop forward to.
More blood pressure right now, if I could.
So the big keys of this, you have to pace the heart rapidly so there's no blood pressure. You have to give appropriate pre-medications to get the blood pressure up, because magically when you stop someone's heart who has bad heart failure, they don't bounce back. Our anesthesiologists, our cardiac anesthesiologists really drive the show on this. We work closely with them. But this is Joe just showing an example of, he's actually directly inserting this catheter into the mannequin through the exact port, using the exact tools that we're using in the clinical setting. So it's identical tools. Every manipulation you do on these catheters, the buzz, the dials, everything is simulated in this environment. You want to hop forward one more?
But it's not. Yep.
This is an example of an error. We actually put this valve in.
Okay, pacemaker off.
The valve is covered up about 50% so that it doesn't embolize. And we inflated this valve without retracting, a critical step in the placement of this. But what it does is we're able to simulate an error in this situation, not following the steps for device deployment directly. And you can actually see the exact steps of this. So this is a great environment for these simulated adverse events, where you can train, here's what happens if you do X, here's what happens if you do Y, and here's what happens if you do Z. There's no real rallying of these in the real human condition. This is a horrible thing, and this is an emergent open sternotomy. So it's very important to expose people to these errors in a simulated environment. Next one.
Inflate.
Inflating.
So this is just an example. So they've inflated the balloon across the aortic valve. All of this is X-ray based. So training cardiac surgeons who've not done this in a cath lab for their entire training is a big challenge, and that's why simulation really helps get these guys up and running. What you can see now here is Joe's actually not only having to do X-ray, but he's having to do X-ray while pulling the delivery system out of the sheath. So again, this is a way to train folks on X-ray. It's appropriate steps in the deployment of these valves, wire skills, sheath skills, all with the same equipment that we're using for the commercial release and research aspects of this. I don't know if there's one more there, but I don't think so. But so just to finish up here, I think I've hopefully highlighted some of the areas. This is such a rapidly evolving field that it's really hard to keep up with this. But all of the simulation companies have basically been able to do all of these things. The simulation companies, all the vendors now have the full offering of these. You can simulate just about everything in interventional cardiology in 2012, which is great because there aren't really vendor-specific programs. All of these are being offered both outside the U.S. and Canada and Europe for training, as well as in the United States. I think right now we're sort of, I think Rebecca's question about how do you get the societies on board is a good one. I have the pleasure of working with her again with the SCAI and the American College of Cardiology, trying to sort out where we are, what's the state of the state for simulation, and we're just working on a white paper on simulation interventional cardiology to try to get this out in the community of what the training opportunities are now, that this is a much more robust technology. And hopefully you guys have a chance to see that today. I think the challenges of collaboration, Rebecca, are funding, and funding. I suspect aren't dissimilar from many other things in medical education and training and assessment of competency. I do think that our biggest challenge and what I've learned from David and Richard is that the integration of the didactic curriculum is really important, and you need societal ownership of that, which seems to be something that's fairly critical for success of this, as well as standardizing and validating the metrics and broad dissemination of the simulation training is really, I think, we're going to take advantage of this storm of new technologies to really integrate this into the culture of endovascular medicine, and particularly with our vascular surgeons, our interventional radiologists, and our interventionalists. I think we can all get on one common platform. So I think there are still some unanswered questions. Many of you might have the answers to these. What's the value of this? Does it improve clinical outcomes? I think it will, particularly for these new things where we need to get up to a learning curve of expertise incredibly quickly with these novel technologies. Will this continue as a part of maintenance of certification? Rebecca will know the answer to that, or hope. And then how do we best incorporate this into the training from a cardiology societal perspective? We have 4 societies that oversee cardiology, which also is a challenge in that we've got a very split group of folks. And then finally, the role in testing. I really think that if you are in the third standard deviation below others, it probably is a sign that you shouldn't be doing endovascular procedures. And unfortunately, we aren't like the surgeons in cardiology. We allow folks through 6 years of medicine, and if they make it into interventional cardiology, the number of people who don't become interventional cardiologists is almost zero. There are people who are not very good, but we don't have the 6 years of technical sort of assessment that our surgical colleagues have, and the surgeons have been much better about, they bring fellows in and test them on a simulator to determine whether they're even going to take them into their program. So they've been much better at integrating this into their sort of selection of folks, and we need to do the same in interventional cardiology. So to summarize, I think simulation training and testing really is widely available now in interventional cardiology. The costs are coming down. The technologies are really balanced. It's a much more balanced playing field between the multiple simulators, but we need both a didactic curriculum that most people agree on as the key elements, as well as further investigation. And then there clearly needs to be a societal and accreditation approach, as well as a certification approach on how we incorporate simulation in interventional cardiology. With that, thank you very much. I think I kept this on time. I'm close.